So there's still a lot of progress that we need to make in metastatic CRC. Certainly we have an increased understanding now of how to sequence our available therapies, but I think what we see for targeted therapies is a challenge of durability, that the tumors are adapting, finding ways to grow despite this treatment, and we really need to figure out how do we understand those adaptive mechanisms, how do we short circuit them, and how do we sequence therapies to get best results. It may be that intermittent re-challenge efforts in the targeted therapies setting may be beneficial, but also a number of targeted therapies, next generation set of drugs are in development. For immunotherapy, the challenge is really how do we get beyond MSI high? I think the clear evidence of activity and trying to think about how do we extend that benefit to a microsatellite stable population. But there's really been, aside from the Rego-Nivo study and maybe a smattering of other smaller, less promising results, there really has not been a clear signal in the direction to go. And I think we really have to think about how do we target the two different subgroups of colorectal cancer, the immune desert, where there's really no sign of any immune engagement, where we need to do vaccine strategies, T-cell, perhaps bispecific T-cell engaging strategies, oncolytic viruses that may be beneficial, or the immune-excluded subgroup of colorectal cancer, where it's really about improving the local tumor microenvironment to get better responses with checkpoint inhibition. And here it may be that targeting MDSCs, targeting TGF-beta, and other stromal and immune-excluding phenotype is what we need to be doing to move forward.
One of the holy grails of metastatic colorectal cancer therapy it would be to make MSS colorectal cancers immunogenic. And we have tried in various different ways and we have failed. Now, the most intriguing combination that I've seen recently is a combination of regorafenib and nivolumab. These were surprising data actually presented at ASCO 2019, tucked away in a drug development poster where Japanese investigators combined 25 patients with gastric cancer and 25 patients with metastatic colorectal cancer. In the 25 patients with colorectal cancer, 24 of them were MSS, clearly not microsatellite unstable tumors. And the combination of regorafenib at mainly 80 milligrams per day, plus nivolumab in standard doses, showed a response rate of 36%, which has never been seen before. Now, we still need to see whether these data can hold up, let's say in a Western population, expanded population, and eventually potentially run a phase 3 study to really identify whether this holds up in a randomized trial. But these are the most intriguing data I've seen so far to make MSS tumors respond to immune therapy, augmented immune therapy. And this combination of a kinase inhibitor plus an immune checkpoint inhibitor is actually something which has shown before to be active. There's a lenvatinib pembrolizumab combination approved for MSS endometrial cancers. Strong efficacy. We've seen recent data that tumor agnostic, this combination of lenvatinib plus pembrolizumab actually makes sense. We've seen recent data of a combination of bevacizumab, atezolizumab in HCC first line. The idea of a VEGF inhibitor plus an immune checkpoint inhibitor. I think this opens the door for various different combinations we can test in different tumors.
We have made a lot of progress in the management of metastatic colorectal cancer. I think the future is bright. I think we're going to continue a path towards subpopulations of colorectal cancer. We've clearly defined now the BRAF population, the HER2 amplification. We have a little bit more work to do. How do we target HER2 mutations, for example? How do we target MEK1 mutations? I think no doubt in my mind, we still have to work on IO combinations. There has been some signals with tyrosine kinase inhibitors with regorafenib in combination with nivolumab in patients with microsatellite stability from a Japanese patient population. I think we need to follow that signal. But I think where we're going to be in 2 to 3 years from now is more in a position where we're defining better what small populations with metastatic colorectal cancer benefit more from targeted therapy. And if there is another small subpopulation that responds from immunotherapy that is microsatellite stable, how do we define that population? So that's where I see our field moving in the coming 2 to 3 years. We certainly need to develop new mechanisms in targeting colorectal cancer. I think cellular therapies are going to be coming up as well. And these include modified T-cell infusions that are engineered to fight colorectal cancer. There is some work being done on CAR-Ts, but which is still in its infancy. And there is also some more work being done on bispecific antibodies. So I think I would expect more data coming from those studies, which would lead us, hopefully, to the next generation of large randomized phase 2 studies and phase 3 studies.